No, it's okay.
Good morning or good evening, depending on where you are in the world, because this is a worldwide webinar being seen in all 4 continents of the world. Here it's night time, and I'm pleased to have with us today Ben Stecher, who's actually, I believe, just across the road in Barcelona. Across the road. And then also from Utah and in Canada, we've got 2 guests who Ben will introduce much better than I can, so I'm not even going to try. These webinars are designed to explain and help people with Parkinson understand better the aspects of Parkinson's and ask some of the questions which really need to be asked. How can we help ourselves? We've done that. Are there medicines available in America which are not available in Europe? Rytari, Imbrisia. And we had the FDA and EMA on the webinar. Didn't get an answer, I must admit, but we had an interesting discussion. Tonight, I think, will be even more interesting, knowing the speakers and knowing Ben. If you want to send a question, you can use the YouTube chat and we'll get that through to Ben and he'll answer the questions as they come through. I'm actually going to be leaving because I'm nothing to do with this. I'm not a neurologist. I'm not even a person who understands any of what they're going to be talking about. But I am the director of the European Parkinson Therapy Centre here in Italy. I have 17 years of Parkinson's. Our centre has grown from 1 therapist to 33 staff in a very short period of time. Has become extremely well known because of the work we do with Becky Farley, with Jay Alberts, with Davis Finney Foundation and many others on working on quality of life and helping people learn how to improve their symptoms and how to live with Parkinson's. It seems such a small thing to say, but quite a lot of people who have Parkinson's don't live with Parkinson's. They are subjected to Parkinson's. And that's very sad because Parkinson's you can live with. I'm hoping that Ben will back me up, being another Parkinson person. Okay, if you would like to see this video afterwards, it will be on our website. That's www.parkinsonstherapy.com and just hit the webinars button. And you're welcome to see tomorrow the replay if you think it's that good. Otherwise, I'm going to hand over to Ben. It's a great pleasure to have you with us tonight, Ben. And could you introduce your guests for me? And I'm going to disappear. Do my magic act.
Bye, take care. Thank you, Alex, and thank you to everyone at the European Parkinson's Therapy Center. I first met Alex about 5 or 6 years ago, I think, when I took a visit down to his center in Barrio Terme. And I'd recommend to everybody with Parkinson's, if you have the opportunity to get there yourself, you should definitely try. I remember seeing 2 or 3 people that walked in, they were on crutches, and they were able to walk out of that therapy center about a week later on their own. So it's really some amazing things that he's been able to do there just by applying some of the things that he's learned along the way to managing this disease a little bit better. Now, my guests today are 2 people that know a lot about this word that we call Parkinson's disease. The first is Professor Alfonso Fasano and his counterpart there, Professor Alberto Espay. I know both of them actually. We have a shared link in Toronto through Professor Tony Lang. Tony Lang is somebody who I reached out to about, I think 7 years ago. And I was first diagnosed about 10 years ago. I reached out to him 8 years ago, just trying to get to see him in his clinic. He pointed me towards Alfonso, and then he also pointed me later down my journey towards Alberto in Cincinnati as well. But my first question, I'm going to start with Alfonso. I'm going to ask the same thing to Alberto, though, as well afterwards. But I've already asked this question to Alfonso in a previous podcast we recorded. So I'll give him the first crack at this first question. What images, emotions, or clinical phenomes come to mind when you think of the word Parkinson's? So when that word like pops into your mind, what kind of images would you use to describe that word that we call Parkinson's disease?
Yeah, thank you, Ben, and thanks for inviting me. It's a pleasure to be online with friends and to spread the word and trying to improve communication and knowledge around this complex condition that we call Parkinson's. So back to the question, yes, I remember when you asked me the first time, the first image that came to my mind was a day full of work. This is to me, this is my job. So when you say Parkinson's, it means, okay, I need to go to the clinic and I'll be there from 9 to 5, seeing mainly people with Parkinson's disease. But after the initial reaction to the word Parkinson's, what comes to my mind is it's a label, and I guess we all agree that this is just a label. It's just a way that we use to communicate amongst ourselves, and perhaps for symptomatic clinical trial or symptomatic management, it's good to know that whatever problem the patient has can be attributed to a condition that we call Parkinson's disease. But it's no more than a label. From a practical standpoint, if we want to be a bit more biological, I will call Parkinson's disease any condition where there is a degeneration of the nigrostriatal fibers, which are fibers that bring dopamine from the substantia nigra to the striatum, without the degeneration of the striatum, so that if you give medications, and levodopa in particular, there is some sort of improvement of the motor condition. But this is a very reductive way to look at it, because there is no person with Parkinson's like another, as we know well. But if we want to look for a common denominator, that will be it. So that will be my short answer.
All right. Alberto, the same question to you. When I say the word Parkinson's, what are some of the first images or thoughts that come to your mind?
Well, thank you, Ben. I echo Alfonso's sentiment. It's so wonderful to be back here together among friends. I think very highly of you and Alfonso, and so I'm just very happy to be here together. If you had asked me that question a while back, I might have given you an academic answer and tried to put together in a manner that would make me look smart. Today, I would say that the word Parkinson's has become an acceptance of living in different worlds. I can say to someone, you have Parkinson's, and pretend I know what that person's actually, the person's symptoms are due to, or where they come from. It gives me a sense of security, but I also recognize it gives me a way out of my ignorance. I have less and less of an understanding of what Parkinson's is, so that's why I think I would have had a better answer before, and now I have a much less defined answer than I ever could. And I hope, as we probably will discuss in a little bit, that the future is one in which we would say to someone, we're making a diagnosis based on the current criteria. You have something we call Parkinson's, and we'll then make the very next statement, which is to say, I have no idea what that means to you. And then follow that by saying, but we could try to start investigating by finding whether there are abnormalities in certain metabolic, biological pathways, to be able to get to a point where we might then know why you have something that expresses in the manners that we have conceived as Parkinson's, so that we can then define a treatment for your Parkinson's. Meanwhile, here's levodopa to make you feel better. I would hope that that's kind of what the future might look like. And it's not revolutionary an idea. It's taken from the playbook of oncology and other fields of medicine, where the label is simply a starting point. It's not the end point, it's the beginning point where we would say, here's what we call this, have no idea what this means, let's try to figure it out.
Okay, thank you both. So I guess going forward into this discussion and into the future of Parkinson's, whatever that word might mean to other people, I'm wondering about how we're actually going to actually try and make progress going forward. And there's kind of a couple different avenues of thought, but there's one in particular that has recently struck me as being more relevant. Now, we have the causes of these diseases, and there's a whole bag of causes right here on the left. And imagine, if you will, that there's another bag of symptoms on the right. And everyone around the world is trying to figure out which causes lead to which symptoms. My question for both of you, though, and I'll let you guys decide who wants to take this one first. Does it make sense for us to go from cause to symptoms, or should we actually be thinking about going from symptoms to cause?
Alberto, ladies first.
So going back to, so I'm a semiologist or a phenomenologist. I like to think that symptoms are very important to digest, because when we put them together, along with the signs, so symptoms are what patients express, signs are what we can recognize in the examination. If we put them together, we can come down to something that makes sense to us. And it's worked out reasonably well. Where it doesn't work, and we know it, is in trying to figure out how the connection of symptoms will eventually connect with a specific molecular biological abnormality. I think that's not going to happen. Now, do symptoms emerge from molecular biological abnormality? Probably they do. But do those same symptoms always connect with the same abnormalities? Probably not. So in other words, symptoms do come from something that we don't yet recognize, but we suspect is there. But that something will generate a variety of different other symptoms, such that it makes it almost impossible to think that if we can have a cluster of symptoms, that we will then be connecting them linearly with some kind of molecular or biological disruption. I think, unfortunately, that the symptoms are important to recognize, important to continue to keep in the eye of technologies. Now, wearable technologies allows us to quantify them better, but not to assume that if we know exactly what those are, that we could in one day figure out what the biology driving them is.
Okay, very fair.
Yeah.
Yeah.
So a few facts. I tend to say that neurology is the discipline of clinical medicine where we deal with thousands of rare disorders. So we are dealing with thousands and thousands of problems, and sometimes we have to use labels. We can group some of them together. Think about Parkinson's disease, essential tremor. We have many labels, but to some extent, multiple sclerosis, epilepsy, those are all labels. But deep down, we're dealing with thousands and thousands of different physiopathological processes, causes, and so forth. This is on one end. On the other hand, we don't have so many symptoms and not many signs. At the end of the day, a neurological problem manifests with 10, 15 problems. And this is why I always tell people, don't go on Google, because if you Google paresthesia, tingling, you might have everything from a brain cancer to an elbow injury with a compression on the nerve. So we don't have so many symptoms to go with so many causes that we might have underneath them. This is an easy answer to give. As Alberto just said, it's true from cause to symptom, but it's not true the other way around.
Okay. Now I'm going to give you both a chance to kind of play God right now. I did
We are not neurosurgeons, you know that, right?
Well, I did my own kind of back of the napkin calculation, and I came out that there are about 23 million people with Parkinson's around the world. My question for both of you, and I'll start this time with Alfonso, is how are we ever going to actually live in a world where we can effectively deliver therapies to 23 million people? Let's say you controlled all of the global resources in Parkinson's. How would you actually go about distributing those resources such that 23 million people, or however many that there are in the world, are properly taken care of?
This is the question. Actually, let me say that there is an unspoken question that you might ask at some point, whether we will have a cure for Parkinson's. And I think we will. We will. The question is when. I think we will, because it's the history of medicine. So there were conditions like, I don't know, pneumonias where people used to die from. And now, it's an extremely exceptional situation if you die from a pneumonia. And so there is no question that we will have cures, whatever that means. But obviously, the path to a cure is very long, and we will probably discuss this later on. So we will have, let's call it, cure. Back to your point then, okay, how can we unfold and make sure that this is distributed to all the people worldwide? Also keeping in mind that the prevalence of this disease is going to go up. And that's the key problem. There are at the moment, in other conditions, mainly genetic conditions, cures, or something that looks a lot more like a cure. And those are very expensive. I'm talking about some pediatric conditions, or also some retinal problems. We have vectors, we have approved therapies, which cost millions of dollars per one person. So how can we make sure that everybody gets this very expensive therapy? And the reality is that we won't be able to. There will always be disparities in the world. But the good thing is that, and this is something we've seen with technology, over time, with more and more production and ways to produce in a more effective ways, these things will cost less and less. Think about the first laptop computer. It was basically impossible to buy one for a student. Now there's not a single student without a laptop computer, at least in North America. So the same will apply to these cures. So the prediction is we will have a cure. We will have different cures for different people, depending on the real cause of the disease. And this is something that Alberto for sure will talk more about. These cures will be not for everybody. They will be very expensive initially. And then over time, they will become cheaper and cheaper. And in that regard, also the logics of the industry will play a role, because as we know, patents expire at some point. So that the cost of certain products will necessarily go down. And finally, there will be some logistical problems, because let's assume that one of these cures will be given intrathecally, so with an injections in the spine or even IV. Then you need to have rooms in your clinics. You need to have a completely different scenario, where you have no longer the classical patient's clinic, where someone comes, sees you for an hour, and then go home, and perhaps the person goes to the pharmacy to get the medication. This would be something that would require injections clinic or infusion clinic in your own clinic, exactly like happened to multiple sclerosis at some point, or even stroke. If you think about stroke units, we didn't have stroke units before. And the reason we have stroke units now is because the complexity of the treatment has become so convoluted in a way, with so many different angles and also risks, that you need to have a dedicated space. So there will be additional issues, not just related to the cost or accessibility to remote areas of the countries, but also how to really implement these new approaches in the hospitals.
Well said. Alberto, if you were God for a day, what would you do to actually try and treat 23 million people all around the world?
So here's where I like to separate symptomatic therapies from disease modification. So I think that the biggest unmet need now is how to make sure that the entire world has access to the medications that are amazing. We already have, levodopa being among them, right? So we have really great therapies. And many of them are not accessible to many people. So the first barrier that we need to overcome is the delivery. I heard recently one saying that I think we all have heard at different times, but it's worth repeating every so often, that success is 1% inspiration, 99% perspiration. The great ideas, we've had great ideas, and we now need to implement them. And there is amazing progress made in the symptomatic treatment of patients with Parkinson's. Now, where is it that we're making much progress is in disease modification, because unlike symptomatic therapies where lumping is perfectly fine, if we just say this is Parkinson's and we say Jean, Mary, and George have Parkinson's, yeah, they're different, but they have Parkinson's. lumping them into a group makes sense for symptomatic therapies because we're targeting common denominators, dopamine deficiency, most eloquent among them. But Mary, George, and Jim are going to have different causes of their Parkinson's. So what will disease modify? What will slow the progression of Jim's Parkinson's probably will be irrelevant or might be even harmful to Mary and George. And so that part is going to require splitting, not lumping. But we have continued on a lumping approach for disease modification. And so that's why I like to keep the discussions separate. I think there is much to be done from the wonderful symptomatic therapies we have, but we need to start to change our approach for disease modification where lumping will never work. I cannot imagine that there will be large enough group of people that will have a single or even a cocktail disease modifying approach to begin with. Even in a condition that's driven by one gene, cystic fibrosis, if you have CFTR gene mutation, you get cystic fibrosis. And we neurologists think one gene equals one disease, and we've had this discussion many times. No, one gene, many diseases. Even one gene can give rise to a variety of different types of mutations that give rise to different forms of Parkinson's, as you know, with GBA, as you know, with LAR2. With LAR2, it's even dirtier because LAR2, the Parkinson's gene, can give rise to things that don't look anything like Parkinson's whatsoever. So in the field of cystic fibrosis, the first success happened to work finally to slow the progression in only 4% of individuals. And so a small success, but look at the expansion that has taken over since, where now we have not only monotherapy, but multiple therapies that collectively can disease modify 60% of the entire universe of cystic fibrosis patients. So a big deal of it. I think we try to spread too large first success goal. We say we're going to cure Parkinson's. We try to extend too large. We're going to cure Parkinson's at a time, and it might just be that the very first cure will apply to 1% of everyone we today call Parkinson's disease, if we are able to split adequately enough. Just to finish, the last most poignant example of splitting, and it's so far been the only one, is the splitting of people who have Parkinson's with low uric levels. Uric acid, it turns out that it's a very important free radical scavenger, a natural antioxidant we all have, but it's well established that people who have low uric have a high risk of developing Parkinson's. But more importantly, once Parkinson's is established, there is a very clear inverse relationship between the levels of uric and the Parkinson's progression. So those who have the lowest levels of uric have the fastest progression. Those who have the highest level of uric have the slowest progression. It only made sense to have a trial of an uric elevating medication, inosine, actually available over the counter, easy treatment, to elevate the uric in people who had low uric. So this was the first study to split because it recruited patients that only had low uric. It had never been done before. All of the disease-modifying trials simply asked for early Parkinson's disease. People who have Parkinson's, according to somebody like me saying so, and then giving them a molecular therapy and hoping that the whole cohort would actually express some benefit. Well, here you have now 40% of that pie because 6 out of 10 did not have low enough uric levels. What happened to that trial? Nothing whatsoever. So people had a successful elevation of the uric levels, which we thought was exactly what was going to drive then the improvement. And in fact, that never happened. And we've looked at the different ways to cut that data in different, is there possibly a subset of responders? Nothing of the sort. No one responded. And so I just wanted to bring that up, that I think what we're going to need to do is to recognize that if we say no two people are alike with Parkinson's, we need to act as if we mean it when it comes to disease modification.
Okay. However, the journey towards disease modification will begin with better diagnosis. Correct me if I'm wrong as well, if you want.
Diagnosis of what?
Well, I don't know exactly.
Parkinson's or Parkinson's?
My question though is, how are we going to get to, like, there are people, for example, that can claim to smell Parkinson's pretty well. We have dogs that can sniff out Parkinson's. Yet we still don't have any good diagnostic measures of this disease besides the UPDRS, which is a very subjective test. I'm wondering, maybe you can help me understand better. Why don't we have a better diagnostic, a way to diagnose Parkinson's or Parkinsonisms at all, besides just these clinical rating scales we have today? Alfonso, go ahead. Yes.
Well, let me clarify. The clinical skills are not for diagnosis. The clinical skills are just to measure what's going on, and those are useful for doctors to talk amongst each other. So I know that if Alberto tells me, oh, I saw someone yesterday at the UPDRS Part 3 was 45 on levodopa, I would say, wow, this person either has this disease for 20, 30 years or is a multiple system atrophy. Numbers have a sense to us, but not to the patient, nor are they used to diagnose. That's absolutely, it's like, using a meter to decide if you're dealing with a bottle or something else. You just use the tape, the measurement tape, to see how long that is. So that's the first thing. So what was your question? Actually, I forgot about it, because you did the rest.
So how are we going to be able to
how did I know? Yeah. So again, I think we don't have to reinvent the wheel, and we just need to look back at the history of medicine. And this is an analogy that Alberto likes to make all the time, which is oncology. So oncology was very behind, is still behind in many respects, but has done a lot of step forwards over the past decades. Think about breast cancer. In the past, it was kind of normal to hear about someone who died from breast cancer. Unfortunately, this is still possible, but it's extremely rare these days. Why? Because with oncology, we have access to the biological piece. So because of the way this is treated, removing for now the pathological growth, this gives the opportunity to pathologists to dig down into the biology of these cells. And then genetics came, biochemical new approaches came along, and this helped us characterize the really molecular pathways involved in these cells. We are far when we deal with neurological disorders in general, and this is because the brain is a very complex organ, and also because it's less accessible in a way, but there are ways around. All I'm saying is that forget about sniffing this is just for TV shows. We need to have access as much as possible to granular information, which are by definition molecular. Medicine has to go more and more into molecular ways to approach the problem and treat the problem. And an example I always make, and with this I want to see what Alberto thinks, is gastritis or ulcers. There was a time when the only therapy we had for people with these problems was to remove the stomach. So it was a surgical treatment. So back then you had to see a general surgeon if you had gastritis. These days, not only we know that in some cases gastritis comes from an infection, HP, Helicobacter pylori, and if you see that there is the bacteria, then the treatment is the antibiotic. But even when you want to be a bit more unspecific, you want to just treat them, you don't remove anything. You just give PPI, which are drugs that stop the production of acid. So they increase the pH, the acidity in the stomach, and that is enough, and is no longer needed to remove the stomach. So medicine is moving more and more towards a molecular approach rather than just very gross treatments like removing, inserting. Even DBS, in a way, it would be seen as a very rudimental way to treat these disorders. And back to my analogy with oncology, as you probably heard, there's been a trial published in a very good journal where people with colon cancer were treated with an antibiotic, with an antibody. And the antibody was targeting a particular molecule or part of a molecule that only the cancer cells had. And for the first time in the history of oncology, all the patients were treated, were cured. It was no longer a percentage of responders, no responders. No, they all were treated. Why? Because they were going more and more into the molecular mechanism of the disease.
Alberto, so first, would you agree with Alfonso's case for how we're actually going to go from diagnosing to maybe treating? And then what do you say about that gastric case that he just brought up?
Yeah, absolutely. I agree entirely. That's why I also was saying to you, diagnosis of what, right? So the sniffing test would be a diagnosis of Parkinson's, but we're already saying what is Parkinson's, right? It will be different, different people. That's why I started by saying I hope that in the future we say you have Parkinson's. I have no idea what that is for you, right? Because that's the honest. Right. If when you were diagnosed with Parkinson's, you imagine there was a script for you, but you're not following the script because you have a different type of Parkinson's than most people you've actually ever met. So it is I think our patients have been a lot more sophisticated than we have been in terms of recognizing, but we're different, and yet we're told that there is a staging system in Parkinson's, and there are all these expected milestones that will happen to everyone. Yeah, some people are a little more classic than others in terms of that script, but I think that everybody's different. Now, I like that example that Alfonso gave with regards to gastric ulcers. Imagine back in the time how ridiculously crazy that idea was, that people have gastric ulcers because of an infection. And if you look back at that time, it was crazy. And the researchers that came up with this concept felt themselves ostracized. It made no sense that this thing was an infection. I think that we're underestimating the effect of different types of infections in the field of neurodegeneration ourselves. And I can say that there, for instance, we don't think much today, but neurosyphilis caused in individuals affected something that today we would call Alzheimer's disease. With variations. If we treat the cause of neurosyphilis, we're technically curing Alzheimer's in that individual, right? So there is a specific infectious cause for that individual's Alzheimer's presentation. Of course, neurosyphilis can present in a variety of different ways, but here you have a specific cause of it that can be treated very targeted. It's similar to the example of treating gastric ulcers with an antibiotic approach. We might need to start thinking, what about some of these infections could be in some individuals very directly connected to the brand of condition they have? And it may not be a direct connection, it may be an indirect connection. How? Through the generation of what we call a para-infectious process, meaning essentially the development of antibodies against parts of the brain that ultimately end up generating problems that are very much consistent with diseases we currently think of as just primary neurodegenerative process. One interesting example is progressive supranuclear palsy. It looks like Parkinson's early on in many people, but evolves with different features. And there is an antibody that can give rise to something in the spectrum of progressive supranuclear palsy. That antibody is called IGLON5. And now that we know about this, it may be that this could be arising from an infectious process. Of course, it could be a genetic abnormality that gives rise to this, but it's unlikely that an antibody would form so far late without any kind of trigger. So that could be something to keep in mind. I don't know how many, what the proportion of the syndrome of Parkinson's might have an infectious etiology, but maybe as we try to be open-minded about this, it might be that we're going to find some more connection between infections and maybe antibodies that could develop from infections, remote infections in many cases, and what we call Parkinson's.
Can I add something to this, because it's an interesting way to look at neurodegeneration. We are always forgetting the environment. What we are is not our genes. It's not just our body, our build, but also what we experienced. And it's so difficult to have a so-called exposome, I think it's called. So the exposition, the history of your expositions in life, how much of this type of water you drank in your life, how much pollution you were exposed to, how many infections and what type of infections you went through. An example just came recently, I think 2 years ago, with this background, seminal paper, an important study looking at multiple sclerosis in large data sets, and they found that almost all people had a previous exposure to a particular virus, the Epstein-Barr virus. And for this, you need large numbers, but you also need to change the mindset, because it was known that in multiple sclerosis, there should have been a trigger somehow, and the trigger had to come from the environment. We are not quite there for Parkinson's, not because we deny the role of environment, so think about pesticides, but because it's just more difficult to analyze, because Parkinson's tends to develop later in life, and what happens in your life until that point is very difficult to disentangle. And another incredible example comes from a very elegant study. I usually don't like, and I don't quote animal studies, but in these animal studies, they basically created a model of Parkinson's that comes anyways, but it comes earlier and in a more severe fashion if the animal is in normal environment, so it's exposed to microbiota. Instead, the animal in a sterile chamber will still develop the problem, but will be different. It will be milder. So this is clearly indicating that even when you have a gene that causes the disease, you might still have a different evolution. And this is well known to people who follow monozygotic twins. They are identical, yet if they are Parkinson's, maybe one has Parkinson's, the other doesn't have it. Or if they both have, the manifestation is different. And finally, the relationship between inflammation and neurodegeneration. You heard about Iglon 5. There are other examples in medicine, even in neurology. Myositis, inclusion body myositis, can be either seen as an inflammatory disease, but also as a degenerative disease of the muscle. And in fact, there are also genes that can cause a myositis, genes that can cause an inflammation. So it's really a complicated field. But the first step is what we're doing now, acknowledging our ignorance and also discussing how difficult it is to change the paradigm. HP, Helicobacter pylori, people weren't believed because no bacteria can resist a pH so low. Same happened to prion. Prusiner, who discovered prion, wasn't believed initially. And we have many other examples in medicine. So each time you want to challenge the current paradigm, the initial reaction is, no, this is not true. It's not possible.
Well said. Okay, now I want to shift focus a little bit and talk about, because you're both obviously well-known researchers in the field, but you're first and foremost physicians. You have your own clinical practices as well. And I want to talk a little bit about, if we can, the relationship that you have with your patients and how that develops over time. And I want to start really from the very beginning by asking a hypothetical to Alberto first. And if you want, you can feel free to talk about the pitfalls that you've seen in neurology along the way. But I wanted you to ask, let's say you suspected, with all the knowledge that you have today, let's say you suspected yourself had Parkinson's. What would you do? How would you actually go about trying to prove this to yourself, whether or not you had this disease? And who would you seek out? And then on top of that, what kind of questions might you ask your physician or your neurologist to make sure that they were the one that should be caring for you?
I would pick up the phone and call Alfonso, Dr. Fasano, and said, I need you to see me because I have some symptoms that I want you to make sense of and hopefully dispel. That's probably what I would do. Maybe I would travel to Toronto because, of course, Alfonso is there and I would like for him to examine me. I'm not joking with this. That's probably what I would, in fact, do.
What kind of questions would you ask?
What questions would I ask?
Visit? Yeah. Yes.
I would say just examine me as if you were examining any other patient. Try to be as objective as possible. I might say, well, here's what I've noticed, that when I do finger tapping, I don't do it well. And of course, I would give him more information than perhaps other patients would, but I would have him examine me as objectively as he can.
Okay, Alfonso, same question to you then. You don't have to tell me exactly where you go, but What kind of
No,
questions
not
are
joking. At the end of the day, this is actually the main message here is that you don't have to have fancy treatments or fancy diagnostic tools to diagnose what we call Parkinson's disease now. You don't have to have dopaminergic scanning. You just need to have a good clinician. And in that case, again, as Alberto said, I will go to Cincinnati to see one of his colleagues is a very good neurologist. to see Alberto. Alberto, and but then it's also it is also important to look at the type of problems, because if I only have issue with the steady of my hand, that can come from many things. But if I have that, and on top of that, it's been a few years that I act up while I sleep, that I act my dreams. That's quite specific. It's called REM sleep behavior disorder. And when you start putting things together, it's quite easy to make a diagnosis. And I should say, I'm in general a good patient. So when I need help, I'm very agnostic. So I go to someone else and I say, okay, tell me. I pretend I don't know anything, because that's the best way. In my practice, I have many doctors with Parkinson's, and when they start acting like they know, then I start asking them questions to let them see that they know nothing. I mean, I'm not saying I know everything, but I know more than them, so that they stop being the doctors of themselves and they're just relying on someone else. That's the key, relying on someone else. Knowing that that person in front of you can help you and certainly wants to help you is the key. And it doesn't mean that mistakes can't be made, and can be made, and I made many in my life, but the intentions are always the best possible, and you really want this person to have the best care and the best diagnosis. And the other thing is never sugarcoating anything. There's no point, because when I have good news, I want the person to hear me out and believe me. If I have bad news, I always say what it is, and I always tell the person. There was an old way to look at medicine where the patients wasn't supposed to know and the family had to know. It's actually the other way around, because there are important decisions to make. Medical assistance in dying, there are so many things that you need to think about, or maybe your bucket list. You want to do certain things before it's too late. The person needs to know. So never sugarcoating, relying on the person. No, it's not a technical job. It's a very human. It's human interaction at the deep down in a diagnostic process. And what I will ask is obviously what I can do to help myself. But by the way, I already know what I should do. As far as I know, I don't have Parkinson's right now. But if one day I will have it, I know that I'm already doing something wrong, because I'm not exercising regularly. I'm not having a good diet. There are certain things. There is cognitive reserve and there's motor reserve. The more exercise you do when you're in good shape, the better it is when you get a disease. It doesn't matter what disease it is, because it's much easier for a doctor to treat someone who is overall healthy rather than to treat someone, yes, with Parkinson, but also with obesity, with spine issues and arthritis and so forth. So the general rule starts even before you have the problem, which is trying your best to have a good lifestyle and a good body, because problems will come to everybody, and we just need to be ready for that moment.
Okay. Coming back though to some of the pitfalls in neurology. Or actually, first I want to give a little bit of advice to people that might be listening to this. If they're looking for a good neurologist, there's something very important for the whole field, I think, to embody. That's a humility that is very intrinsic to what they're doing, because there's so much unknown, and they have to be comfortable telling you what they know, but more importantly, they have to be comfortable telling you what they don't know. So they have to be able to say the words, I don't know, sometimes to some of the questions that you might have for them. If they're just kind of winging it, or they're making up answers along the way, maybe look somewhere else, because that might not be the person that you want taking care of you long term. Now, my next question though comes from Brian Frey in the questions here. He asks, so what are you doing right now to help us? I'm going to ask Alberto first. What are you doing now to help us better subclassify Parkinson's diseases? How are we good? Yeah, go ahead.
That's a great question, and it's a difficult one. What we're doing that's different is, rather than us saying, we know what Parkinson's is, and we're going to have as many people with the diagnosis of Parkinson's in one bucket, and then have another bucket of people that we think are aging neurologically without any symptoms. We're going to call them controls, and then measure as much as we can from each bucket to try to come up with something that statistically appears to distinguish these two buckets and call them biomarkers of Parkinson's disease. We're past the idea of assuming that Parkinson's represents some well-defined construct, biologically speaking. So what we're then doing is accepting we don't know what Parkinson's is, where it ends, and where Alzheimer's begins, and where Alzheimer's ends, and where frontotemporal dementia begins, and where that ends, and dementia with Lewy bodies begin. We don't know where all these neat, separated syndromes are in relationship to one another. So what we have been doing, and it's actually, Ben, you've been great at helping us in the launch phase of the CCBP and continue to serve as a bit of an ambassador to these ideas, is to recruit people in a cohort to study aging. And that's kind of what we're studying. We're studying why is it that some of us age in ways that are funny enough for us to give the name of Parkinson's to someone, or funny enough to give someone the diagnosis of Alzheimer's. So we're very inclusive in our cohort. We are including people with Parkinson's, but then with a variety of other Parkinsonisms, progressive supranuclear palsy, as we define it, multiple system atrophy, etc. And we're also recruiting people that have nothing that we can tell, but that, who knows if they will or will not develop something. The anchors for analysis are not the categories that we can make some sense of. For instance, we're not, even though we're doing something called deep phenotyping, which is using wearable technologies to measure behaviors, we're not using them to say, we're going to try to figure out what's different between people who have a tremor versus people who don't have a tremor, or people who walk for 3 miles versus people who walk under 3 miles. We don't want to use that as what we call an independent variable. We want to use them as dependent variables. And instead, what we are developing are bioassays of therapies, many of which have been developed already. They seem wonderful molecules. Were already used in clinical trials to try to slow Parkinson's, and none of them did. And the philosophy of our program is that it's not that these molecules were futile. They were actually probably good molecules. We just never knew who they were actually for. And so the assay problem that we're deploying in this phenotype agnostic population, meaning that people that we include with a variety of diagnoses well beyond Parkinson's disease, who the assays will tell us that there is a range of abnormality that render those individuals candidates for therapies that already exist, that we would then finally say, this is the kind of individual, this therapy that has been gathering dust in a pharmacy shelf could be repurposed for. That's kind of what we're doing. It's a much harder way of developing anything, because it is the opposite to what we've been trying to do. Is we generate a molecule, prove that it cures Parkinson's mice, and then we give it to people with Parkinson's disease, thinking, oh, look how the mice model of Parkinson's work with this molecule. It might work on everyone's with Parkinson's, right? Because for sure the Parkinson's model in mice tell us something very meaningful about people with Parkinson's. And all of those efforts have failed. And so we're assuming that some of these therapies, or perhaps most of these therapies, are actually good therapies if we knew who they were for. So we are applying a matching between therapies available and people who are biologically suitable to benefit from them.
Yes, and if anybody is curious or wants to learn more about that program or the thinking behind the program, there's a book called Brain Fables that I would encourage everyone to go and pick up. Now, that's one that I wrote with Alberto. I'm in the process of writing another one with Alfonso Fasano, and I want to put him on the spot and ask him if he can help us to clarify, what is your takeaway message for people who might be interested in picking up our book? What will be the one thing that you want people from the readers of our book to know. And I should start by saying maybe it's going to be mainly about DBS and the future of deep brain stimulation therapies. Go ahead, though.
Yeah, that's something that I've been giving some thoughts for a while now, because it started off as a guide for people considering deep brain stimulation, or for people who just had DBS or are on chronic DBS therapy. So we wanted to describe the experience of Ben, the experience, my experience as his doctor in navigating the choice and how we did it and how we programmed and how is life now. But then the more, Ben, I think this is a mutual sentiment, that the more we wrote about this, the more it became the history of your journey ever since you were diagnosed, which is a very interesting journey, I found, and we all know about it. And more importantly, the our own journey, so the relationship, our relationship. So that's actually the part that I enjoy when I write. We're still, not there yet. We're still working on the book. But anytime there is more of a personal touch or something that happened to us or to our relationship, this is where I think the book is going to be like no other.
Yes, I agree. Thank you.
And now I wanted to say that I asked Ben to please don't be as brilliant as he was for Brain Fables, so that.
So our next question comes from Nathan Morelli, and he asks, how do you approach multidisciplinary collaborations, not only for patient care, but your research for patients and your research, and how do you involve people with Parkinson's in that research as well? Alberto, why don't you try that question?
Yeah, that's a good question, and it's essentially we don't put restrictions. We think that the recipe for success is likely to be not one but a combination of interventions, and therefore there are disciplines outside of even medicine that could be quite important for therapy. Rehabilitation strategies, which is the term that is used for, say, physical therapy, occupational therapy, could really come from even non-traditional therapies. Not only the types of activity that we now recognize, in fact, can be quite beneficial, say Tai Chi, for instance, but even art therapy or music therapy. So there, I think what I just want to say is there isn't a recipe that can work equally well for everyone. I simply recommend for each of my patients to think of something outside of anything they've ever done that includes a cognitive piece and that includes an exercise piece, and then we come up with something that makes sense for that person. But that decision is very individualized, and a lot of the elements needed to make a decision come directly from people themselves. Because if I think something is going to be important and that doesn't strike a chord within the individual I'm speaking with, then that's not going to work. But I think the idea of multidisciplinariness is very important in therapy. It's also very important in the process of our study of aging, also because we need expertise from scientists from very far away fields from medicine, even fields that relate to machine learning, from artificial intelligence, a variety of others that really would have not been thought of as directly relevant to what we want to do.
Sounds like something that would ring very true at the European Parkinson Therapy Center and what Alex has been building over in Italy for a long time now. Alfonso, the same question to you. And also, since we only have about 5 more minutes, I wanted to also ask if there's any other final thoughts that you might have before we wrap this up.
Well, I'll be short because I know that we've been talking for an hour now, and I've been talking quite a lot. But I think we need to have a structure in place where the voice of people is heard. I like aviation. I think aviation is the safest industry we have. And from aviation, actually, I got inspiration for many things I do, including writing algorithms and checklists in medicine. And one thing that we learned from aviation is something called crew resource management. So the job of the captain in the cockpit is not to rule everybody and say what to do, what not to do, but is to make sure that it's a democratic environment where anybody can talk and be heard. And back to the infrastructure that will make this possible. As you know, in Toronto, we have a patients advisory board. So we have a group of patients and caregivers who are telling us what to prioritize, where to go with our efforts, how to do things. Sometimes it's difficult to do what they want because we need to look at reality and see that one of the ideas they might have, they're excellent on paper, but they are not feasible for a number of reasons, including economical reasons. But having them on board and helping us even with designing study projects is now becoming standard as a startup practice, not just in our center, but we have a very active and I'm very grateful actually to our patient advisory board, which I'm part of as a clinician involved in the scientific content. So that will be it. In terms of final words, once again, thank you for giving me the opportunity to be with you this morning or this evening in Italy. And I feel really with friends and with family. I'm not joking. As a matter of fact, Ben was with me and my family in Nusco, and Alberto was there too a few years before. And it's all coming together. And maybe we'll go one day to Boario all together, and I'll bring my parents too. We'll see. But we are all here fighting the same battle, and that's a given, but we should tell ourselves, and we should also say what is working, because we have many things that are not working. We're very ignorant in many regards. Medicine has a lot of problems, and COVID has emphasized many of the problems. Think about wait times, but we also need to acknowledge when things do well. And certainly one thing that has changed profoundly over the past years is what we're doing right now, and also the relationship that is changed profoundly. It's no longer God, but it's more of a guide. And I'm referring to the TED talk by Bas Bloom, where he says doctors from God to guide. And this is what we're here for.
Well said. Alberto, any final words from you?
Well, no, thank you for giving us the opportunity to act like gods today. It's been very, very good to feel like we really know it all. I particularly enjoy being with you, of course, in a God or ungodly equality. My parting thought is we're on this one together. Very much the same sentiment that Alfonso just mentioned. And nothing that will be of great importance will happen in the vacuum, will not happen in one center or in one individual's brilliance, but it will happen as a result of us combining our efforts, our ideas, and working together the best way we can.
Well said. And on that, I'd like to thank Doctors Fasano and Espay for joining us today. Alex, back over to you for any final thoughts or words you might have. And you're muted.
And you're muted, Alex.
Oh, we still can't hear you. Oh well. Unfortunately, it's now time for us all to part. But thank you all for listening. Thank you everyone for attending. Thank you very much to the European Parkinson's Therapy Center in Boario Terme. Again, if anybody's listening out there and is curious, I highly recommend. Oh, there we go.
It's now working. I just wanted to say one very quick thought. The word neurodegenerative strikes fear into the hearts of people who have Parkinson's. But then what we do often is just remind them that every year on their Facebook page, people write, "Congratulations, well done." Getting old is a neurodegenerative condition. It's even worse than Parkinson's. It's going to kill us, of course. I write on people's Facebook page, "I'm sorry you're 1 year nearer to death." It just seems a bit more realistic, doesn't it? And the other thing I wanted to say was, I can totally agree, finding the right neurologist, the right team, I'm fortunate in being followed by Dr. Elia in Besta and his team with because I have neuropathic issues, I have DBS issues, you don't want to know. But I think having a team of people makes you feel much more relaxed. And Parkinson's is something you can live with, but you've got to have the courage to do it and believe in yourself. And thank you so much to Dr. Alfonso and Alberto. It was a fascinating conversation. We've got lots of comments coming through about this being the best webinar we've done yet. This is the only one we've done, so probably that's why.
It's great to be first at something.
Okay, we're going to hand over. We're going to hand over to the music maestro, who'll play the exit music. Bye.